An 81-year-old self-identified white woman is evaluated in the emergency department for an acute onset of severe confusion and fluctuating level of consciousness. All right, so I'm going to go ahead and highlight this in red because this is ultimately the chief complaint. It's acute onset of severe confusion, fluctuating level of consciousness. Continuing on here, according to her daughter, the patient was in her usual state of health until 24 hours ago when she became increasingly disoriented, began seeing non-existent objects in her room, and reversed her sleep-wake cycle. The patient has a history of mild osteoarthritis managed with acetaminophen. She has no history of dementia, major psychiatric illnesses, or substance use. On physical exam, her temperature is 100.6. Heart rate is 98, respiratory rate is 18, and blood pressure is 112/64. She alternates between states of marked lethargy and extreme psychomotor agitation, shouting at the nursing staff and attempting to pull out her peripheral IV. Cardiopulmonary exam is normal. Suprapubic palpation reveals mild tenderness but no guarding or rigidity. Neurologic examination demonstrates diffuse inattention, disorientation to time and place, and otherwise non-focal motor and sensory exam. Okay, that's important to note here. These physical exam findings. Urine analysis demonstrates a leukocyte esterase positive reaction, 50 white blood cells, and numerous bacteria. All right. Which of the following is the most appropriate next step? So ultimately what we're seeing here is this patient is having this presentation where she's extremely agitated to then extremely somnolent, and it just started all of a sudden. We have evidence of fever here, which could mean that there's possibly an infection, and some physical exam findings that may be leading to a possible UTI in this patient, which is not uncommon in a patient that's 81 years old and is a female. And so the other thing that also helps us here is that the neuro exam is otherwise not focal, meaning there's no focal deficits that would explain her neurological concerns here. So and furthermore, we have evidence of this urine analysis having some suspicion for an infection with leukocyte esterases and numerous bacteria. And so what we might be seeing here is a case of delirium, and some key findings in delirium are going to be this evidence of disorganized thinking. There's going to be some level of cognitive deficits, not able to be oriented to person, place, or time. Any of those can be missing. Also, hallucinations are very common, more visual than auditory. And the big thing here is that it happens acutely and it sort of waxes and wanes. And that type of history should tell you that this is most likely getting at delirium. And the key things to treating delirium are going to be mainly supportive environmental factors, like making sure they're oriented to the time of the day, so by keeping the blinds open, having somebody there to reorient them. And then also treating whatever's underlying driving the delirium. So if it's infection related, treating it with appropriate antibiotics. But we'll work through the answer choices here. So for the first one here, IV administration of low-dose haloperidol. So haloperidol is an antipsychotic medication used commonly when you want to sort of chemically restrain someone. And this would make sense if this patient was getting more violent and becoming a threat to herself or others, but it's never the first step for somebody that is going through delirium. So we'd move away from that answer choice. B, IV regular insulin would be appropriate if you think that maybe hypo or hyperglycemia is driving the delirium. There's no evidence this patient is a diabetic and has a history of maybe missing her medications or anything like that. So it's less likely that maybe hypo or hyperglycemia is driving her delirium. C, oral administration of low-dose lorazepam. So this is actually the one choice you never want to select because this can cause paradoxical agitation in a patient that's elderly. Benzos are never really the best choice for treating delirium. They actually worsen the situation. So that's never the correct answer. D is sort of what I was explaining, provision of environmental reorientation. So kind of like, making sure they know what time of day it is by having the blinds open and having somebody check in on them and reorient them, and then also treating whatever's underlying. So in this case, it's likely a UTI that's driving her delirium, and so antibiotics would be appropriate. And then lastly, scheduling a non-contrast CT of the head. You do this if you're suspecting there's a focal neurological deficit, maybe some kind of brain bleed or stroke that's driving this presentation. Based on the neuro exam,